Good evening, everyone, and thank you for attending this Day 2 activity for the national launch of diabeteshealthequity.org. This project is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol-Myers Foundation Together on Diabetes initiative. It is my distinct privilege to welcome you to tonight's panel discussion entitled The Three-Element Approach to Achieving Diabetes Health Equity. It is moderated by Dr. George Rust. Dr. Rust is a professor of family medicine and is the founding director of the National Center for Primary Care at Morehouse School of Medicine and currently serves as co-director with Dr. Dominic Mack. The NCPC's mission is to promote excellence in community-oriented care and optimal health outcomes for all Americans. He received his medical degree from Loyola University School of Medicine and completed his residency training in family medicine at Cook County Hospital in Chicago. Dr. Rust is board certified in both family practice and preventative medicine and holds a Master's of Public Health. Before joining Morehouse School of Medicine in 1991, Dr. Rust served as medical director of the West Orange Farm Workers Health Association. Before we bring on Dr. Rust, I have just a few housekeeping items. We've planned an engaging dialogue tonight, and you will have the opportunity to interact with the presenters at the end of the presentation. So please jot down your questions and hold them until the time when you will be directed to type them into the Q&A box at the bottom right of your screen. Now, without further ado, please help me welcome Dr. George Rust.
Thank you so much, Sabrina, and it's great for me to be here. As many of you know, Ms. Sabrina Jackson is Program Director for this initiative, the diabeteshealthequity.org web portal, and for the Partnership for Diabetes Health Equity that we have between Morehouse School of Medicine and the Bristol-Myers Squibb Foundation's Together on Diabetes program. It's a great honor for me to be here with you tonight and to have a couple of guests with me who I consider to be the real experts on the topics we're going to talk about tonight. So I'm going to just give a quick framing kind of outline of some of the themes that we want to explore tonight, and then we'll have a conversation led by two real-world experts, Dr. Stephen Kaufman and Dr. Steve Tierney, and then we'll have an opportunity for discussion amongst all of us and allow for questions from the audience as well. When we talk about the three-element model, just to frame our conversation tonight, what we're talking about is the magic of getting everybody to play nicely together and making all the pieces work in an organized system of continuous care and outcomes. One way to summarize it is community, clinic, and outcomes. We often have people inside clinical practice settings doing their very best to make sure that the quality of care they provide is excellent. And in the same neighborhood, there are people in the community working very hard to make sure that people live healthy lifestyles and engage in healthy self-management behaviors. And then somewhere else, someone is noticing outcomes like hospital admissions and emergency room visits and adverse consequences of diabetes and hemoglobin A1C levels. And what we're talking about tonight are going to be two examples of organizations that have figured out or are continuing to figure out how to tie all these things together to make sure that the clinical practice excellence is tied in and closely interwoven with community engagement, community partnership, and that all of that activity is informed by measurable outcomes in a rapid cycle feedback loop that drives change and helps us all to do a better job of getting to the best possible outcomes, optimal outcomes, but also equitable outcomes, elimination of disparities, and achievement of equality in diabetes outcomes for all. My first guest tonight is Dr. Steve Kaufman. Dr. Kaufman is the Deputy Medical Director of Cooper University Hospital's Urban Health Institute. He also serves as Assistant Chief of Endocrinology of the Division of Endocrinology, Diabetes, and Metabolism, Assistant Professor of Medicine for Cooper Medical School of Rowan University. He's also the Medical Director of the Cooper Diabetes Center and the Staff Endocrinologist for the Camden Coalition of Healthcare Providers, where he focuses on decreasing disparities in diabetes care in underserved communities and transforming primary care practices into patient-centered medical homes. And I must say, the first time I heard Dr. Kaufman and the team from Camden talk about what they were building out and the way that they had integrated all of these elements, I was so impressed. I just want to sit at their feet and learn. So that's what I'm going to do for the next few minutes. And Dr. Kaufman, please take us where you'd like us to go.
Thank the folks from Bristol-Myers Squibb and Diabetes Health Equity for this opportunity. I'm going to see if I can advance the slides, or if I'm doing that. If not, I'll need some assistance. Oh, there we go. So let me tell you a little bit about the Camden Coalition and our mission. It's to bring together healthcare providers, hospitals, physicians, and community organizations to improve the care and coordination of healthcare within Camden, New Jersey. There's two components I'm going to be focusing on tonight. One is our work with super utilizers. Those are patients who are outliers in the healthcare system and are using resources at the emergency room and hospital more than other patients, fragmenting care and driving up cost, as well as focusing on the second component of my presentation, which is going to be our diabetes programs in the community. Let me tell you a little bit about Camden, New Jersey. I'm actually amazed as I talk to people from around the nation, and they seem to know some of the negative aspects of Camden. And on this slide, I've got Camden City, and then below Camden County. So Camden City is rather small. It's about 9 square miles with a population of about 77,000 individuals. So it's nice in that we can drive across the city in no time. Compared to the county, you can see that the median family income is $29,000 compared to $57,500. It's a much higher percentage of minority populations, and it's a much poorer area compared to the county, with 36% of individuals living below the federal poverty level. There's also a serious crime problem in Camden. Our murder rate for 2013 was 12 times the national average. So we have some barriers, we have some complexities to care, and challenges in providing care. As we move through this, I'm going to talk about kind of a triangle, and I think one side of the triangle has data, one side of the triangle has clinical redesign, and the final side is patient engagement. We're going to talk about each of those components as we go through this. So with all these complexities to care, and in Camden there's 3 hospitals. There's several primary care offices, 1 academic medical center, and then several small primary care offices throughout the city, about 12 of them. And the question is, how do you put this all together with folks working going back 10 years ago in kind of a completely fragmented, siloed system of care where primary care doctors are running from room to room trying to catch up with patients who are coming out of the hospital, have very complex, numerous medical and behavioral health conditions. And the Camden Coalition wasn't started as a ability to transform healthcare. And I think it's important as we go through this to realize that there are definitely small steps that any office or community program can take. The Camden Coalition was started as a breakfast club to share experiences between primary care providers and community leaders. But it was realized by the president of the coalition, Dr. Jeff Brenner, that there needs to be a better way to put this together. That within the city, if we can collect data, and he drew from experience with the Camden Police. You recognize that the police don't distribute resources across the entire geographic area, they look to where the crime is. And the idea was, can you go to the hospitals, get their data, and then design a plan to look at outliers, whether it's patients who are being hospitalized for diabetes, asthma, falls, and try to get coordinated care to those patients. So let me give an example and an analogy here. This would be like Target, Walmart, and Kmart all getting together, sharing all their data, and then deciding to come up with a plan of convincing patients not how to shop there. Because this was the effort. It was going to be to get patients who were super utilizers using the emergency room and hospital and get them better care in the primary care office so that they're not showing up in the emergency room and hospital. Let's take a look at some of that data. So if we look on the left at ED visits in the past 12 months, we can see the US average compared to Camden residents. The patients at Camden are using the emergency room about twice as much as the national average, and then that slows down over the age of 65. And similarly, patients in Camden tend to be hospitalized more, and this follows the national trend that you tend to be hospitalized more if you have behavioral health problems or you have multiple chronic illnesses. And what you see and is demonstrated at the bottom is that 1% of patients drive 30% of the cost. And I said that there's 77,000 patients in Camden. So now we're talking about 700 to 800 patients, and that's something you can kind of get your arms around. And really a group you can work with. If you look at the next 12% of patients, that's 50% of the cost. And 80% of the patients are not using the emergency room frequently and are only accounting for 10% of the cost. You can then take a look at and actually map out where these are happening. And so when you do this, there are hotspots. There are areas in red which are driving most of the hospitalizations and most of the costs. So as the same way as we talked about the analogy with crime, what you see is that patients are not equally distributed in their use of emergency room and hospitalizations. We had two buildings. One was an apartment building with had 3,900 visits for 615 patients across 5 years. And that was a cost of about $12 million in receipts and a much greater charge of $83 million in charges. So, these buildings are responsible for millions of dollars in cost each care, but that also means there's a specific building or block that the care can be targeted to. So let me step back and talk about then some of the diabetes specific programs that we've been able to use. And I want to start with diabetes education. So for all the high tech we have here, where the real engagement happens is with the high touch components. And when we started our work in Camden, there were 2 diabetes education programs. One was at a federally qualified health center. There wasn't advertising outside of that program. The other was in a primary care office. They were not referring one floor up to the diabetes education program. And they were seeing about maybe 30 visits a year. So they weren't getting much traction, which means it wasn't being resourced. And one of our early wins was kind of breaking down the silos. The lead diabetes educator for the coalition brought together all of the diabetes educators in the city. Said this is a great opportunity for us to meet and try to figure out how diabetes education should be taught, not separately from institution to institution, but across the city. What is the message about diabetes we want to give? It went from 2 programs. The coalition established 2 programs. 2 other hospital systems got their programs running. Now we have multiple, 6 total English and 2 Spanish diabetes education programs in the city. And it was really started by one person saying that we can do this differently, we can do this a little bit better. that has actually morphed and grown to getting the attention of the Harvard Center for Health Policy and Law, and so they're introducing new policy changes for how diabetes education is reimbursed at the state level for Medicaid. So we've gone from 2 education programs to really working on policy change, and it's been a dramatic improvement and impact on diabetes education. The second thing we've been working on, and I've been quite enamored with, especially work with the Urban Health Institute, and I'll just give a shot of it here, is our using standardization and protocols. So doing group visits, trying to standardize some of the work that happens around diabetes. This is endocrine. Well, I lead this group visit with a nurse practitioner, and a pharmacist, seeing patients, and we're able to do a few things. We're able to engage patients who have not been engaged around their diabetes. We're able to offer the patients a combination of clinical care and diabetes education. And we're able to improve some utilization. And one of the hard parts we know is that if you start programs and we're not able to use the resources, the staff effectively, that hospital systems and community programs aren't often eager to keep those going. There's a cost to this, and we're actually I'm able to see more patients in the group visit model using an interdisciplinary team than I see in the suburbs individually. So it's able to go back to the hospital system and promote this kind of continued care. There's also able to offer through the coalition mentoring with primary care providers around diabetes. So there's regular case conferences for those who are interested. And we're actually hoping to promote that not only to get CME credit for those individuals, but also to do this on a statewide through a telementoring program. And that's not that's not fully settled, but we hope that's the next move from Cooper Medical School. And the third component I want to talk about is the care management component and focusing on outliers. And we were able to embed a nurse into one of our larger primary care offices, focus on those patients who have a hemoglobin A1C greater than 9%, using their EHR data. Work on a program where the nurse was assessing the patient's readiness to change. So while we were offering interactions with all patients, we were really targeting those folks who were saying that they're pretty ready or willing to start making a change, and working with those 121 patients who have an HbA1c over 9%. At 3 months in, they were able to decrease the hemoglobin A1c from about 11% down to 10.1%, and then by the 6-month mark, the hemoglobin A1c was down to 9.2%. So while at the 6-month mark it wasn't a goal, it was still significantly lower than the starting point. And the last thing I already mentioned about some of the policy change we're doing, but all these elements are building up to the Medicaid ACO, which is now part of New Jersey law and hopefully being started by the coalition in the very near future. So if I think about some of the essentials to care coordination, we want to be able to have that target population. You don't necessarily need some sophisticated health information exchange. We need to, we can, as we did in the primary care office, just look at the EHR, or just by simple examination of charts, see who your target population is. If you have the advantage of a health information exchange, that's great, but I don't think that's necessarily needed to make an effective intervention. I think you need the appropriate team to work. Getting the right person for the right job is essential. And I think that's both a bottom-up component and a top-down. I think having the leadership of any organization being able to support the work that's going on and able to give the resources needed for the job. And part of that, I think, comes from just understanding what the mission is. And I've gotten a lot of attention from physicians and other folks in our organization just by understanding that we can't have patients sick at home, sitting on the couch and then going to the emergency room. And a lot of what we do is around improving access and getting patients in to either the primary care provider or their specialist as is necessary. And then I think understanding the role of community partnerships. It amazes me that there's often a lot of folks either in medical offices or community within our community partners that are kind of doing the same thing, understanding where their mission is, where their role is. And obviously healthcare does not occur in a vacuum. We can look at all the determinants of care, and there's no one that's the most important. But we clearly know that it's not from the physician's office alone. And so finding those community partners and trying to enhance that work. Along the way, we've definitely had to combat obstacles in our work towards equity. I talked before about the importance of having a mission statement or a specific goal. And I think being able to communicate that clearly to not only folks in your organization but outside your organization really helps us to stay on point and on our mission. We try to hire as much for attitude as for skill set. I work with the Urban Health Institute with physicians from 20 different specialties, and some of them are incredibly talented physicians. We have very talented nurses and medical assistants, but in the end of the day, I really need someone who understands the mission of health equity and what we're trying to move forward in Camden. And I'll say, as we tried to combat these common obstacles, is sometimes we need to fail, and we've make it a habit of trying not to fail. As my son says, don't make it an epic fail. Make it a little bit of a learning process. We are very much into PDHE cycles. And trying to do the simplest experiment we can to try to figure out what the problem is, how we can come with a solution, and then run that experiment multiple times over. So the experience gained through these programs are invaluable in expanding our benefits of the superutilizer approach and transforming diabetes care in Camden, and hopefully across the state. We'd love what we're doing to be a model of care that spreads out across Camden, across New Jersey, and across the country. And so I'll just finish by going back to that triangle I talked about earlier. And we have data components. Those data components can be very intricate health maps. Data it gives us a clue of where to look. It doesn't solve problems. We look to that human touch. We look to our clinical design, whether it be group visits, mentoring nurses and primary care providers on diabetes care, enhancing diabetes education programs across the city, as well as our patient engagement strategies. Whether that be in an office or targeting a high risk group such as superutilizers with home visits, follow-up programs, and connection to community programs. So at this point, I'll stop. I'll turn it back to Dr. Rust. Thank you.
Well, thanks so much, Dr. Kaufman. That's extraordinary, and um, obviously the elements are there. The strong use of data, the obvious improvement and redesign of the whole clinical enterprise around achieving better outcomes, and at the same time the engagement of communities, not just communities broadly written, but specific buildings in specific neighborhoods where real people live, free-range humans, as we say, who don't live in our exam rooms. What I'd like to do is shift gears and let everybody kind of absorb that and now maybe have a different flavor and see some of the same elements, but maybe operationalized in some unique ways. Dr. Stephen Tierney is going to speak with us about the Southcentral Foundation NUCA system of care. Dr. Tierney is the current Chief Medical Information Officer and Medical Director for Quality Improvement at Southcentral Foundation. He's been there since 1995 and the last 10 years as the QI Director. He's trained as a family physician and completed his residency at University of Maryland Hospital in Baltimore, but also spent time in the Coast Guard and has degrees in microbiology and spent some years working as a staff microbiologist in Bethesda at the National Institute of Allergy and Infectious Disease at the National Institutes of Health. He went to medical school at the Uniformed Services University, also in Bethesda. He's trained as an acupuncturist, still maintains an active practice in the primary care clinic at Southcentral Foundation, and he's also the medical director of their complementary medicine program. He is nationally known and internationally known for his work in clinical quality program design, data management strategies, and integration of complementary medicine and community partner integration in the practice of primary care and in the focus on health at the community level. So Dr. Tierney, thank you for joining us, and let's hear from you. And we may need you to click your microphone on.
Okay, how is that? Am I on there?
You're there.
Okay, good. Is that too loud? All right, good show. Well, thank you so much for that. I'm very happy and to join you all today, and hopefully we'll offer a little bit of additional perspective from our view. And thank you for the introduction. That was quite generous. So I, as mentioned, is from Southcentral Foundation. We are out of Anchorage, Alaska. And let's see, to advance, how do I advance there?
Now at the bottom lower left corner, there's some arrows. If not, we can do it for you.
Oh, there you go. Okay, I think I got it. Okay. At the bottom lower left corner. Ah, there you go. Got it. Okay, good show. Okay, so what I'm gonna talk about is a very slightly different perspective on care, and I'm gonna use diabetes as a context, but this is how we've created change in our healthcare environment. What we've found is that when we look at improving anything, we change how our strategy is formed based on the perspective that we have. So I'm going to use a few examples, and one is when we measure things and when we display them, we have an example here of what is our organizational performance, and this is from a little while ago on diabetic eye exams, for instance. Now, if you look at the red line is what our goal is, and the blue line is where our stretch goal, and it looks, to all appearances, to be that we're doing okay, but not quite at our stretch goal. If we change our perspective a little bit, we can see that actually the distribution of the individual providers is quite variable. You can see that we've got a range from 82% all the way down to 34%. And it means that in the past, when we did projects for performance or performance change, we used to look at aggregate performance, but we ignored distribution. And what we learned over time, that as we tried to create change within the organization, that our most instructive was the distribution and the variance in performance, because that showed us a lot more of what we were trying to learn. We can find that there's probably something unusual going on with 82% and something, not so spectacular going on with 34%. But how do we use that as a strategic advantage to be able to say that this will guide us in our efforts to create a new outcome? What we have found is most staff are generally overwhelmed with the work that they do at the point of care. As you pull them away from the point of care in actually delivering visits, which is really their primary mission, we find that it's difficult for them to really improve when they find their performance is wanting. So what we have built underneath our performance management system is an infrastructure where we have an action list that auto refreshes based on an automatic computer search every 7 days. So what this will do is provide each team member a transparent view of who are the people that they've successfully or maybe not so successfully reached, and what are their values for A1C, LDL, blood pressure, creatinine, etc. But all that, while it was interesting, was only the really tip of the iceberg. We actually said, let's look at the larger context. The people who are super utilizers are people sometimes who have diabetes, but sometimes have other conditions too. And we began to think about this a little bit differently, and it was also much from the work from Camden Coalition, as many years ago, as many of you have read the Hotspotters article, found that 2 buildings in Camden generated most of the visits. And we began to be curious about that and to say, was it about the condition? Was it about the disease that we were trying to get right? Or was there something unusual in their social context that caused them to struggle? And was it something larger than just the condition that they had, or was it something bigger than that? So what we did was loaded our entire population into a geomapping tool. And we took all our names and addresses from our master patient index and put them into a tool. And this is what it looks like in Anchorage. Well, we started to get curious and to say, are there patterns that we could really find as we discovered patterns in provider performance? Are there patterns in the people that we serve? And would that be as instructive as the patterns in provider performance to tell us where is the best practice and where is the worst practice? Well, what we learned is that if we overlaid all the people with diabetes and we looked at what their A1C was, intermediate control, or in good control, we actually began to observe geographic patterns where we could find some people clustered heavily with diabetes. There were some areas of town that had no diabetes at all, and some places in town that all the people with diabetes actually were in good control. So that caused us to be a little bit more curious to say, was it the diabetes that was creating the problem, or was it more their social context that had influence over whether or not they were doing well or not doing well? So we dug a little further into that, and we said, okay, well, some of these people, as we remove the charge tables from our electronic medical record, we're spending a tremendous amount of money on. And so we actually identified by individual, and we use charge as our surrogate for cost, because cost is very difficult to get down to the individual person level, because it means you have to attribute each Band-Aid or 4x4 or injection to each individual person. Charges were a much more sensitive way to individualize by person, although they only approximate costs, but they were easy to obtain. So we were able to discern of all of our diabetics what we were spending with the composite of lab, X-ray, and medications. And we found some spending a tremendous amount of money and some not so much at all. We went a little further and we said, is there additional information available about the community that may begin to explain this odd distribution of diabetic control or lack of diabetic control? So what we did was leverage some of the commercially available data sets that are actually available for a price that pull together a wide variety of information from Health and Human Services, from Bureau of Census, crime statistics, etc., that actually begin to define in a grid square block the average age, gender, education, home price, credit score, income, family size, etc. Many different, and there are too many to go into, but demographic information about the neighborhood. Now, this offers a unique opportunity. If you know where the people live, if you know what their condition is, if you know how much you spend on them, and you know what their socioeconomic context is, now you can begin to look for patterns. If you were to further drill on this information, you could actually start to develop what are hotspots of significant cost or inconsequential cost. And then you can begin to divide these by where is it that we spend a tremendous amount of money for getting A1Cs of 13 and LDLs of 150, and where is it that we begin to spend a very small amount of money for A1Cs of 6.5 and LDLs of 70. It's interesting because as we looked at performance distribution for providers, we began to look at the performance distribution for the customers that we served. That became even more interesting because we actually said this becomes a mathematical equation. The provider plus the customer plus their condition plus their social context equals an outcome with regard to cost and quality. Well, we got even more curious about that. And we said, is there variance between the individual providers given the same people that they serve? Well, we actually found that in between the lifestyle groups, there was actually tremendous variance with what we spent on the respective neighborhoods, as they were. But then, as we drilled even further, we found the clinic teams had variance among themselves. So what we had found in our efforts to improve is that not all people with the same condition behaved the same or had the same context, and not all providers who served them also behaved the same or approached the clinical process the same way and had variance. That made us even more interested. So what we actually started to do, and what we have done for all our professional medical staff, which is all the doctors and nurses we employ, is personality profile each one of them. And what we have found is we can directly map personality qualities that lead to a highly likely collaborative, engaged conversation with a customer as opposed to a less likely. And what that enabled us is to have a window with how might we coach and how might we engage providers to perform well, not just in diabetes, but in any chronic condition that they might follow. Because what we observed is the same distribution of poor performance and high performance, or high cost and low cost, existed actually across the continuum for COPD, for asthma, for congestive heart failure, for diabetes, for thyroid disease, for rheumatoid arthritis, and I could go on. But what it was strongly driven by is the people who were involved in engaging in the game together. And that was the providers that we employ and the customers that they served. So we got a little bit more interested. And we said, well, what does that mean to us, and how might we improve? Well, we actually began engaging them in professional coaching. And we connected with the Gestalt International Study Center and have since developed a 5-day intensive coaching program that actually allows us to do the personality profile, look at the consumer demographics, and then coach individual provider teams into things that we now are able to map to higher levels of performance. And I think that's about it. So I think we're probably ready for whatever questions that you might have.
So I'll be happy to start. So we're interested in this, and as we showed, Dr. Tierney mentioned, there were a couple of really hotspot buildings in Camden, and one's an apartment building, and we said, well, what if we're going to do everything? We're going to put everything in the kitchen sink in this building, put a primary care office on the first floor. So patients could come down and be seen right there. There was a nurse there full time. We had massage and art therapy and yoga for the participants, and so this is bringing the healthcare right to the community. And what I can tell you is that obviously not healthcare is extremely complex, and 3 years later we're still trying to figure this out. We you know, what was obvious is that patients who had their own primary care provider didn't necessarily want to engage with another one, and that was a part of a learning experience. But it's even bring that to the community, right in the apartment building, had its own challenges, and we, as I said, are still trying to figure out what is the secret sauce to work, and so that's one example. And as we look around Camden, we do engage with different community groups and different points, and I think the best probably example, at least for diabetes, is just the diabetes education we've been able to to bring around the city.
Oh, you guys are freezing a little bit there. Can you hear me okay? Okay. You know, we looked at this as a consumer exercise, and we began. Oh, okay. I'm sorry. How was that? We were breaking up a bit there. Um, uh, so we began to observe in the community other industries that were actually doing some very creative work. For those of you that follow the news, Target actually got successfully sued for predicting accurately that a 15-year-old girl was pregnant based on her web-based behavior. For us, that was a very interesting event because what they had found is a way to recognize patterns of page views and purchases and attribute that to a health outcome. Well, we began to think if Target can do this with no physical contact or no prior relationship based on web behavior, if they can predict pregnancy, what should we be able to do in healthcare with all the data at our disposal and all the pattern recognition over time that we could potentially leverage? So we started looking at this as a retail business exercise with Walmart and Kmart and Target and Amazon using predictive models to find out what it is that you like, what it is that you have, and what it is that you will want next. With very high degrees of accuracy, Netflix can actually say, here is the movie that you're going to want to watch next. And if you have ever used Netflix, they're quite correct in many cases. So how can we start to use this in the same way in healthcare? And what we began to do is build essentially big data models, which input the personality qualities of the provider, the socioeconomic context of the consumer, the health conditions of the consumer, but their pattern over time of use of the system. So what it's led us to is to say, if you ask for a pregnancy test, regardless of whether or not you are or not pregnant, that becomes a leveraged moment. If you ask to have an STD screen, whether or not you're positive or negative is less relevant than the fact that you believed you had an STD. And that in and of itself was instructive enough to us to say we should act on that and use some sort of organizational response to be able to work
Cultural
upstream to improve your health outcomes.
dimensions to
What we begin to
the
find
teams
is
that
that
you've
pattern
built in
recognition
Alaska,
has been well
as
developed
well
in the
as all
retail
of the
industry world, but
engagement
not very
with
well
those
leveraged in
hotspot
healthcare.
buildings in
So our
Camden,
sort
New
of
Jersey.
next direction is to really
How do
continue to
you
expand our
close this
big data
loop so
approach
that
and look at
people are
this as
engaged
really
right
sort
where
of a
they live in
macro
their day-to-day
model where
activities,
people teach us what they
don't have to
need
live in a
through their
clinic to
use
make
of
their diabetes
resources
better,
and the response to resource
but at the same
innovation
time you've
over
got
time.
people in the community who care about getting everybody to a healthier outcome.
Did that? Sorry. Yes, I can. It's just a little spotty sometimes. It's breaking up every so often.
So I'll start then. I mean, I don't think in Camden we're seeing that path at this moment. I mean, there's places that do this pretty well. If we're talking about having the community, if I understand the question, having the community understand what their health needs are, and then coming back for to the healthcare system with that. There are community leaders within Camden. One is the Camden Churches Organized for People, which is a fairly large organization, kind of moving forward with addressing community not only concerns but community needs, and then pulling that back to the major healthcare centers. So they're asking as a moderator or third party in that communication. I think there's a need for patient advisory boards within primary care offices, and we're just starting to move down that path. To some degree, the Camden Coalition as an organization works as that and tries to moderate what the health should be. But I think we're just starting down that path, and I wouldn't want to suggest that it's a paved road. I think there's probably places around the country that do this a lot better than we're doing it at this point.
And I look at this. Quite a lot. What first happened as we did the shift was our entire board were members of the community. So these were lay members of the community that actually drive our direction and agenda. Now, they're often not involved in the specific mechanics of how this is deployed, but the priorities, the direction, the purpose and mission of the organization is completely determined by our board. We said as an organization, when we began that journey, as we took over from the federal government, is that we want to make it impossible to distinguish where the organization ends and the community begins. We want to literally become almost indistinguishable from the community. So as a result, we've engaged in very specific behaviors that sort of enmesh us with the community itself. We start recruiting our workforce at age 12. We have a program where we bring in many people in primary school to do work internships in the summertime, and then bring them back over years, and then use them as the people that will fast track into positions when they finish high school, or if they want to go on to college, support them through college. So as a result, we have people that are 28 years old who have been with the organization 15 years because we've literally grown them from the ground up. One of our goals as an organization is to employ a high number of the community. So right now, 68% of the workforce is people who live in the community that we have groomed in many cases from before they were, old enough to even consider having a job, to now being, several years into their career. The other thing that we want to do is learn from the community in ways that look more like Google or more like Amazon. So we have people that roam the hallways all day, every day with iPads that are linked to servers that do pulse questionnaires about their view of care, their engagements, their the degree of which they felt heard or they participated in their health care, and we feedback that as part of the performance scorecard for all of our healthcare teams. We like to use that as ways that we redesign as we get constant stream of comments, probably about 6,000 a quarter from the people that we serve in almost real time at the time of service delivery.
Clinicians and
As we
organizations
now get
to
to
reach out to the
satisfaction
community.
scores
And
that are
in a way,
robust,
it's a
clinical
push
performance scores
outward.
that are robust,
At what
and
point,
teams that are more
especially in
mature,
an Alaska
now we want to
Native-owned
shift to a
organization
more
or
Yelp-like
a
environment
community-governed
where
FQHC,
provider
at what point
performance
can we
and recommendations and
make the turn toward
referrals
it being a
by the
pull,
customers that they
that the
serve are
community
all
itself
transparent to the community?
understands what it needs and is asking for the right things that will help them get to the better health outcomes? Do you see a path to that? And that's for Dr. Tierney or Dr. Kaufman.
So,
We actually have a specific target. Sure.
Go ahead, Dr.
Oh,
Tierney.
no, go ahead. Go ahead.
Oh, okay.
Okay. Well,
So I'll go. This is Dr. Kaufman. I'll go. So, you know, we recognize that we get these great feeds from the Health Information Exchange, and every day sit down with the team of the coalition and see who's been in the hospital, when was the last time they were in the hospital or emergency room before this, to look at their patterns and decide if what sort of intervention is required. At that point, there's a care management team that's assigned to the patient. That's typically a nurse, an LPN, and a health coach. We try to use a tiered system that is, if possible, we're meeting them at the bedside, but the nurse is going to do the initial assessment and evaluation, develop a care plan, which is a very brief intervention. We want the nurse to meet them at the home, and then transition care very quickly to the LPN and then to the health coach. And the health coach is the one that's going to guide them into the office. We recognize that you can have a great data feed, you can have a great high impact data system, but that at the end of the day, the patient needs to land back in the primary care office. And we do that with the health coach. The health coach is the person that's going to have the most interaction with the patient. They're going to be seeing the patient in their home. They're going to be accompanying the patient to their medical visits and help with that coordination of care, often through multiple physicians, and then back to their primary care provider until there's some stability and the patient can be discharged back to routine care. So we use. Oh, go ahead.
sure. Well, we have several.
Mm-hmm.
Oh, sure. Well, we have several approaches. We recognize that we're trying to deal with several problems simultaneously. There is the medical technical aspect of whatever condition you have, diabetes, heart failure, HIV, whatever. And there's the things that we need to do, as a medical organization to attend to: are you on the right cocktail? Are you receiving the right medications? Are you getting the right requisite follow-up at the appropriate interval? That's about organizational performance. But what we want to do is support the relationship as much as possible. So for us, the medical home team always remains the medical home team. When we need to augment the medical home team, what we do is continue to work through the medical home team. So we'll give you an example about HIV care. Does every primary care provider keep up to date with every last new drug cocktail for HIV? Well, no, of course. They change so quickly, sometimes it's difficult to keep track of, and sometimes you may not have had someone with HIV for some years. But as you get one, rather than interfere with the relationship, which we recognize has tremendous leverage, what we do is we have case coordinators who would come in and say to the panel, you now have someone who has a unique condition that may require special care. We're going to support you and follow them with you, but we're going to leave them in your hands, but allow, but have us coach you from the outside to make sure that the new standards for Hep C, the new standards for Hep B, the new standards for HIV or whatever else that we're trying to support that we have an augmentable team for, is in place. So that's more the medical technical end. We also recognize that people have a social context, and that social context has a profound effect on their feeling of wellness, their use of resources, or their likely to comply, in a way that adds meaning for their health condition. So we say we need an organizational infrastructure for that. So one of our big programs around that is elder care. We say loneliness and isolation has clinical impact on whether or not you're going to go to the ER or come to your, medical home. So instead of using the medical home as a surrogate for social support, what we did is say, don't divert the primary providers and now have them be social support, the social support network, add to that. And so what we have is an elder care program that actually sponsors luncheons, that will visit your house, will check in on you. In our case, will bring you actually native food that are probably difficult for you to get from your, town of origin. But what it does is recognize that we support people in very different ways, but all through the same venue, either through a psychosocial, an emotional, or a medical technical, aspect. And so what we need is a game in all of those venues to appropriately fully meet the needs of the consumer at the community level.
Do in the clinic.
Welcome to the Partnership for Diabetes Health Equity website. This is a partnership between Morehouse School of Medicine and the Bristol-Myers Squibb Foundation. I'm going to focus only on our Learn, Share, and Connect element model in this video, and we're going to start with best practices in our main menu. We have 4 categories available: clinical, community, health outcomes, and tying it all together. And if we click on one of these categories, it will take us to a timeline that will populate with stories for sites where champions are doing great things in the community. Here's our champion. We can see a video, download tools and templates, and also link back to other best practice stories. But most of all, if we click on this image, we'll go to a PowerPoint presentation that loads in the cloud. There's nothing to download or anything to do, and we can see the PowerPoint presentation that gives us information about the site in its entirety. We can also close this tab and still have our site available to us. Next, let's talk about our share element, in which we have resources available to you, tools and templates that can be downloaded, as well as other resources from CDC and PubMed. We can go to tools and templates and see categories available, in which you can click on any of these categories and go to a page where documents are available to you to download, and these are free to the public. If we talk about our Learn element, we can go to our training page where we have webinars, PDFs, and other videos available to you in timeline form, where you can look at these and view these 24 hours a day, 7 days a week at your leisure. We also have our Connect element where we have a form available to you. Again, available to the public to be able to read 24 hours a day, 7 days a week. However, you must be a member in order to post a topic or comment on a topic that has already been posted. So you can do that by going to our login register button in the top right corner, and you can register for free. And then once you're a member, you can log in and go to the form at the bottom, put in your topic, what your message or your question is, and hit submit, and your topic will be posted to the forum. Thank you and have a wonderful day. Enjoy the site.
That's water or what you need to do. We're going to take about 2 minutes to take a quick
Yep.
look at
Can
what's
you hear me, Dr.
available
Rush?
on the diabeteshealthequity.org.
Okay. What you want to go first there, Steve?
I can try to hit that. It's a pretty complex question, so let me see if I can go through that. So we're, again, I think driving at people in the community and new ways of engagement, if I'm understand the question in full, and then the emotional component with the data-driven aspect. So it's an interesting question. And it reminds me of the business model that businesses have their customers, but what they're always trying to do is find out who their non-customers, who are you not reaching. And I think when it comes to engaging people, it's that's what we want to get at. The folks that we're reaching now that are coming to community organized events, coming to education programs, coming to our offices, are getting care. It's the folks that are at home that we're not getting. And I don't have an answer. I'm not sure anybody has the perfect answer on how we reach those folks. What we do know is people stay at home, they're isolated, they tend to get sick, and they get more distant from the healthcare system. And in Camden, I can tell you what we've tried. We've definitely reached out to different community organizations. I mentioned Camden Churches Organized for People as an advocate for patients. We've also reached out to different food organizations, so food share organizations and farms within New Jersey who have been able to bring in not just messages, but actual food to people within the community to try to engage them around healthy eating. We have a real food desert in Camden. We have no grocery stores within the city. Most people shop at small corner stores, which typically have one or two vegetables. One of those is often corn. And so, we've tried to reach around different areas of need and try to pull in the community through that. The other part of the question was the data-driven approach and its intersection with the patient's emotional health. Data gives you a clue to where to look, where to approach patients. It doesn't tell you all about the patients, and that's where we really look to our high touch, our care management teams, working with primary care offices, working with our community partners to understand those emotional needs. I can tell you that within Camden, it's something we struggle with, that I think around the nation, behavioral health is under-resourced dramatically, yet we know that patients with chronic illnesses who have behavioral health issues are much more likely to not go to their primary care provider and to end up in emergency rooms.
All of these
I'll
elements
see if
together.
Kearney,
We are getting some questions coming in, so I'm going to go ahead
4,000 miles away,
and
they have been able to
read
tackle
one or
the
two of those
behavioral health
now
and chronic
see if
health
I can
issue.
Well, what we do is we look at behavioral health and the more medical health are one and the same. So for us, we have moved to an integrated model where all of our primary care providers have a team of 3 people that support them. They have a nurse case manager, they have a certified medical assistant, and also a clerical support person. But if we take 5 of those primary care provider teams, they're supported by 2 behavioral health consultants, 1 integrated pharmacist, 1 integrated midwife, and 1 integrated dietitian who's also a certified diabetic educator. Now what that does is give you sort of a composite environment. So for us, be it education, be it lifestyle change, be it reproductive, be it mental health, physical health, we actually have the capacity to treat you on the fly. So as I walk into somebody now and say, I'm about to tell you something that's probably going to be very, very intrusive for your life, that you have diabetes or heart failure or cancer or something. And what I'd like to ask you is, this is going to have some things that we're going to have to do medically, but also emotionally for you. And we want to recognize that both are important components to support. And we have our behavioral health consultant who can join you usually within 10 minutes of identified need in our system, or integrated pharmacist or integrated midwife. So what we want to do is create an environment where all of these are on the fly, and be it your blood draw, your EKG, your mental health counseling, your primary care, your reproductive health, or your pharmacy needs are all dealt with on the fly in the same context, in the same room where you don't move, staff move around you. Now, all that said, I thought there was a very good point about what are the barriers around making this a more engaging people where they live. What we have found is if we look at healthcare as the office visits, and we look at doing the office visit faster, what we've really done is taken what I call a blockbuster approach to improvement. Blockbuster said people like to rent videos. What we're going to do is rent more videos with a greater selection, with more stores, faster. And they did. The problem is they forgot to ask what was the point. Because as soon as Netflix came along and said, why are you renting them? Why are you even buying a DVD? Just stream them online. What Netflix did is they said, we're not trying to do incremental improvement of what we do today. What we're trying to do is figure out what's the point anyhow. Somebody wants to watch a video. Let's make that happen. For us, using the office visit as the means by which we broker all these interactions is our rate limiting factor. Getting out of our own comfort zone, which means meeting people where they are, using email, using voicemail, using text, using integrated providers, responding to them in many venues besides just the office visit, besides just in our office and sending them to other offices for these other components of care. How can we think of the customer experience and what would they like and redesign our healthcare system delivery model around that? And for us, all of our business cards have all of our cell phones, all of our emails on them for all of the team members, so that the customer uses us as a composite team based on their perceived need, knowing what it is that we can offer them. And when they do come to see us, we will see them and we will not move them, we will move ourselves as a new way to approach business. What's interesting is this actually creates a leaner model of care, because every time you create a transfer, you now have a gap or a potential for risk or falling through the cracks, and you also have to create a new way of intake and queue. So what we do is essentially eliminate what those transfer points would be, move all the care around the customer, and get to their needs based on however they view them. What we do is we look for partners in all venues. So we look at the church. You know, for in Alaska, for the Alaska Native population, it happens to be the Russian Orthodox Church as probably one of the prominent members. We look at work programs about retraining or job retraining or employment placements. And what we have is a specific strategy to partner with, transfer information, and then transfer people between these two in a way that actually, we can track to say who's going to which, organization, and how can we actually find out if that's returning investment on the back end. So we can actually track somebody who we have sent to, for instance, our Job Corps training program, and find out whether or not that has impact on their visits to the emergency room, their cost of meds, or their visits to primary care, and their health outcomes as measured by biometric data. So what's really interesting is, we have actually found ways to get measurable value out of these things that we don't even run, but we can leverage, which is actually interesting when you look at, how should you invest in your community?
So I think I mentioned earlier that we do a lot of work with Camden Citizens Organized for People, which is a coalition of churches from around Camden, have been around for many years, and are interested not just in the medical components, but many of the non-medical components of what's going on in Camden, and involved in helping to have safer neighborhoods, better lighting, more parks for children. And so there's a constant kind of look to them for what is what is the needs, what are the needs within Camden, not only for healthcare, but for, as I mentioned, food safety, and other integral components to a person being healthy. Specifically from a religious or a church standpoint, and there's other community organizations we've looked to, but let me give Dr. Tierney. I want to be just respectful of time.
Oh, no worries. No, that was really it. And I think you're right. We're really just beginning to scratch the surface of this. And I think when you see organizations that are more mature, they have gotten at least their head above water with the usual business of managing supply and demand, and are now beginning to emerge to what's next after that. But I think where a lot of organizations are still stuck is, how do I survive the basic medical demand that I have today, much less go into what's next after that, but I think this is just, work we just need to continue to hack away at.
That's great. And of course, sometimes they don't need us. One of the things we find in the best practice examples that we see from around the country is that in many communities, the partnership with the clinic is one piece of the puzzle, and the clinician team and the primary care team is an important piece. The behavioral health team is an important piece. But there are folks doing community gardens, there are folks doing community walking programs, there's group support, there are coalitions being built, and many times those become one of the most important components of building health equity, even as it's connected to excellence in the health team that's more maybe medical in its orientation. Some of these community organizations are not started by us and are not run by us. One of our audience members says, Dr. Tierney, please explain how you incorporate community organizations that are not part of your organization into your diabetes program model. So how do you partner well?
So I'll just go ahead and mention that something I should have mentioned before, but one of our initial early success around diabetes was working in what's called the Fairview section of Camden, and it's a little nice circle, and there's a primary care office, and the primary care office was sending patients to the suburbs to the suburbs for their diabetes education. It was clearly not working. There's problems with transportation for many of our patients, for many of the people of Camden. And I have a little camera problem here. And across the circle, we set up within the Fairview Community Center a diabetes education program. So this is where patients were turning, the community center that is, was where patients are turning for a lot of their basic needs, information about what's going on in the community, anything from exercise programs to shopping, and we're able to introduce diabetes education right across the square from the primary care office, and where patients are really going to for their basic needs and information about the community. And kind of another example of how we're to work with the community for and just slip in some extra diabetes education on the side.
No, I've just enjoyed the discourse, and it's certainly lovely to chat with all of you. I have to say again, much of our geocoding work was triggered by your work in Camden, and how can we continue to refine that? My congratulations. You're a big inspiration for us.
Well, and likewise, we'd like to, I know there's members of the Camden team and the Urban Health Institute who'd love to come out to Anchorage and see what the whole system's doing right there in person.
Well, we've invited Jeff in August if he has time. So we're certainly, you just ring us up,
Okay.
Well, that's right. And of course, it may be somewhat freeing to know that we don't have to be in charge of all this, right? But if we do community partnerships right, there are moments when we are in the supporting and cheerleading role, and the folks who are working on safe neighborhood walkability or food security or eliminating food deserts or coming together in organized walking programs, or in Brazil I've even seen jog mobs, which are an answer to the fears people had about exercising one person at a time. So they just form massive groups that go out and do this. In many of these roles, we can be supportive and encouraging and lend our voice to give credibility or to give encouragement without necessarily having to build it all by ourselves and make it all happen. I want to make sure that we have opportunity for anyone else who has questions. We're coming close to the end of our one of the comments that was typed in that we have both providers and community members and patients on with us, and so we're very grateful to have this model being lived out even in this conversation of people.
You're very welcome. It's a pleasure.
Are trying the best we can.
Thank you, Dr. Rust and Dr. Kaufman and Tierney. And to our audience, thank you for taking a moment of your time to spend with us this evening. I would like to reiterate what Dr. Rust said, that here at diabeteshealthequity.org, our intention is to be an online resource center and virtual community for those of you who are out there in the space of providing best practices in diabetes care. So remember, during the next 2 days, we want to connect with you. Join us tomorrow at 12:30 p.m. Eastern Standard Time for our Day 3 event entitled Care Coordination, a virtual site visit to the 3-element model. Also, you can tweet us at P4DHE, which is PFORDHE, and use the hashtag PDHE. You can like us on Facebook, and of course you can visit us at www.diabeteshealthequity.org, your online diabetes health equity resource center and virtual community. When you're on our website, you can post a comment on the forum, read a best practice story, download a tool or template, or if you have questions, comments, you know of a best practice story or a diabetes health equity champion, please email us at info@diabeteshealthequity.org. One other reminder to complete the survey that's in the bottom right-hand corner of your screen just to give us feedback on how we're doing and what you'd like to see us do. This project is made possible through a partnership between the National Center for Primary Care at Morehouse School of Medicine and the Bristol-Myers Squibb Foundation Together on Diabetes initiative. Thanks again, everyone. We look to see you tomorrow at 12:30 p.m. Eastern Standard Time. Good night.
Good night.
Good night. Thanks.
Good night.